Good morning. We're going to take a little tour of sepsis this morning. These are sort of some of the topics we'll touch on today. We'll review some basic pathophysiology, especially how it relates to our clinical management and sort of the direction of sepsis as we move forward and improving the care of children with sepsis. We'll review some definitions, as again, they're important when we think about management. We'll talk in more depth about management guidelines with a specific focus on early recognition and treatment, which is really where the focus is at this institution and around the world, and really that key first hour after recognition of sepsis. And then we'll talk a little bit again about where the management of sepsis is headed, I think, in years to come. So first, just a little slide about the impact of pediatric sepsis. There are about 75,000 children hospitalized each year in the U.S. for severe sepsis. This accounts for 4.4% of all admissions to children's hospitals and 7% of admissions to PICUs. In China, where the incidence of sepsis is slightly higher, there are 360,000 cases per year, which is an amazingly high number. And the estimated U.S. national cost of adult and pediatric sepsis is $2.3 billion. If you kind of drill down a little bit as who's affected most, 50% of severe sepsis occurs in infants. 49% of children with severe sepsis have some form of underlying disease. The source of infection is predominantly respiratory, as are all things in children, which is different than adults where bacteremia is more common. The mean length of stay for children with sepsis is a month, with a mean cost of $40,000. Mortality is actually surprisingly hard to define, and that's because when you have so many children with underlying disease, it's often unclear whether they died from their primary disease or from sepsis, but we estimate it to be between 10 and 20%. If you look more specifically at septic shock, the mortality still here in resource-rich countries is 30%. If you look in resource-poor countries, it's 40% or higher. And the mortality has decreased significantly even since the 90s, when it was over 50%, even in countries like the US. So this is still quite a deadly killer and kills many children every year. So we'll start with a case. This is how I imagine you pediatricians sit in your offices every day, hanging around. I haven't been in the clinic for a while, but I'll just go out on a limb. This is you guys. So you get a call about a 12-year-old patient who's healthy, very reliable family. You know them well. He is febrile and vomiting, and also fell and cut his arm at basketball practice yesterday. They put a Band-Aid on and he finished his practice, but they were just wondering if there's some relation to this. So you bring him into the clinic. He's febrile, he's tachycardic, he's tachypnic. He does have a small cut on his left arm where he fell, but it's not draining. It really doesn't look that red. He's been vomiting since midnight. There's no diarrhea. He says his thigh is also hurting where he fell. So you do a rapid strep and you decide this has to be gastroenteritis. You've seen about 5 or 6 kids who have the same symptomatology, who have gastroenteritis, but you decide he looks quite dehydrated. So you go ahead and send him to the ER for evaluation and maybe some IV hydration. So he shows up at the emergency room. Fever's down a little, still tachycardic, less tachypnic. In the ER, he gets an IV fluid bolus, an antiemetic. They send a CBC, but they decide after 2 hours he's looking a lot better. He's able to keep down a few sips of water, and so he's discharged. So that night and the next day, he continues with vomiting and fever. In the morning, you call to check on him. He's now had diarrhea, so everyone's sure now this is gastroenteritis. He's still having fever, so you advise some ibuprofen and acetaminophen. But by evening, you get called again. He's not tolerating anything by mouth. He's more weak, and the parents say his nose looks a little bit blue. So he's advised to return to the ER, where he's resuscitated, requires immediate intubation. He's admitted to the ICU, and he dies within 48 hours of multi-organ failure due to overwhelming streptococcal sepsis. You can see how this decision tree happened, and this is actually a true story. of a boy in New York, Rory Staunton, who died in 2012. And the press was pretty negative towards both the pediatrician and the large university hospital that cared for him, both in the ER and after, saying that this was bad medicine, that this was a little-known condition that children shouldn't die from. And if you can see the one at the bottom, he died after scraping his arm. So these were really negative things that changed a lot in how New York State has new regulations, which we'll get to, about managing sepsis. But again, you can all see how these decisions were made. And we're going to go now into sort of the pathophysiology and the clinical management, and we'll come back to this case at the end to try to tease out, where decisions should have been made differently and how we can avoid having something like this at our institution. So this is a little bit of a busy slide, but I think it's a nice summary of what the host response is in sepsis. And it's important to really understand what's happening at the cellular level so we can see why our therapies work and don't work. So the host response to sepsis is characterized by, in the top panel, which is in red, pro-inflammatory responses, and in the bottom panel, which is blue, the anti-inflammatory immunosuppressive responses. And the direction and the extent and the duration of these responses are determined by host factors, which is the environment, genetics, age, other illnesses, and pathogen factors, so the microbial load and the virulence. And inflammatory responses, again in the red, are initiated by an interaction between these PAMPs, or pathogen-associated molecular patterns, that are expressed by pathogens and that are recognized by a variety of different receptors on the host cell surface and inside the host cell, the most well-known of which are the toll-like receptors. And so these receptors recognize these pathogens, these PAMPs, and initiate this chain of inflammatory responses that eventually lead to necrotic cell death. Now, unfortunately, when the cell dies, it releases danger molecules or danger-associated molecular patterns that can reinitiate this entire inflammatory cascade. And on the other side, you have the anti-inflammatory response, which causes immunosuppression and enhanced susceptibility to further infection. At the same time, in addition to the inflammatory response, you have a dysfunction at the endothelial level and in the mitochondrial level, and this is where organ failure comes from. So organ failure is really due to microvascular thromboses that are caused by impairment of anticoagulant mechanisms and also activation of coagulation. And these are mediated by a variety of factors. The most well-studied is activated protein C, which is decreased in sepsis. And then all of these things lead to poor tissue perfusion, poor tissue oxygenation, loss of barrier function, and eventually organ failure. So many of our therapies are aimed at reversing or preventing some of these things, although in essence we're really not that productive at preventing these things. But all in all, in the end, sepsis is really a clinical diagnosis. And if you look at sort of the criteria for sepsis, in all of these definitions, there's only one lab value, and that's white blood cell count. So if you look at the SIRS criteria, SIRS being the systemic inflammatory response syndrome, which is really a constellation of symptoms and signs, including abnormal heart rate, respiratory rate, temperature, and a high or low white blood cell count. Just 2 of these changes need to be present to qualify to have the systemic inflammatory response. So once you have that, plus a infection or suspected infection, you are now septic. And then moving on to severe sepsis, it's sepsis plus organ dysfunction, which can be diagnosed using lab values, but also, again, just clinical signs of respiratory distress or poor urination. And septic shock no longer requires hypotension. And that's a really big change from previously, and change from the way that adults are diagnosed with septic shock, and recognizes that in children with poor perfusion, taking a manual cuff blood pressure is incredibly unreliable. So what you really need to look for is clinical signs of poor perfusion. And in fact, the American College of Critical Care Medicine has many definitions of shock, none of which include hypotension. And their definition of poor perfusion is decreased mental status, decreased urine output, decreased pulses and mottled extremities, and even moving down into fluid refractory, catecholamine-resistant shock, or refractory shock. There is nothing that mentions blood pressure. And this is a really important take-home point in that when you're looking at children who you are concerned for sepsis, do not depend on the blood pressure to be either reassuring or to wait to diagnose sepsis. This is in quite stark contrast to adult guidelines. So the adult surviving sepsis guidelines, which have been through a variety of reiterations, use tremendous numbers of lab values to diagnose sepsis. So their organ failures are very clearly defined by abnormal lab values. The most commonly used ones are hyperglycemia and lactic acidosis. And this recognizes really the difficulty with laboratory evaluation in children. We've all been in that situation where you just cannot get labs. And I think the difference between adult and pediatrics is really meant to recognize that you should not wait for laboratory confirmation of any of your diagnoses. You need to use the clinical skills you have to assess that your patient is poorly perfused. So what we have are the Pediatric Sepsis Guidelines. These were first published in 2002 by the Sepsis Task Force led by Joe Carcillo, who we had the fortunate luck of having speak here a few years ago on the topic. And these guidelines have dramatically changed the outcomes for pediatric sepsis. And these are the three of many studies that show how much better our sepsis management is now. In 3 studies, both looking at the implementation of sepsis guidelines in a variety of different settings, mortality decreased significantly. In a community hospital setting, the mortality decreased 30% over a 2-year time period. In an ICU setting, using central venous oxygenation monitoring as goal-directed therapy, again, you're looking at a reduction of almost 30% in mortality. And in another ER setting, looking at meningococcus, mortality decreased from 20% to 1% using these guidelines. And we'll go into more detail of the guidelines, but it just goes to show that when you use a really stratified approach to sepsis, you can improve outcomes. So these are the guidelines. We're going to really focus on the top 3 boxes today. The top 4 boxes are sort of ER management, below is ICU management. I decided not to bore you with what we do in the ICU. And also, we don't want to reveal our secrets. But we're going to really talk about the top 3 boxes, which are really the key components to improving survival of sepsis. It's the early recognition and the early management. So what are the goals of that first hour of resuscitation? The goals are really to maintain or restore your ABCs, airway, oxygenation, ventilation, circulation, with a key focus on heart rate, recognizing that persistent tachycardia is a very strong indicator of poor resuscitation. There are a variety of different ways to monitor for these improvements, and the goal is to have normal endpoints at the end of the hour, normal pulses, normal urine output, mental status, glucose and calcium. Blood pressure is starred because even at this point, blood pressure may still be difficult to measure. And if you have other clinical signs of good perfusion, it is acceptable to follow those alone. And we've seen many patients who you check a blood pressure, it's quite low, but they're communicating with you, they're making urine, and you can be reassured by those patients because, again, they may still not have normal perfusion, but peripherally, but as long as they're mentating, their vital organs are getting the appropriate blood flow. So if we zone in on the first top box, this is sort of the recognition part of sepsis. This is minute 0, and it's recognizing decreased mental status and perfusion, recognizing that you are in fact in shock. And the only piece we'll talk about is this established IV-IO access, because I think you cannot move forward from this point until you've established IV-IO access. So with the sepsis guidelines and with the American Heart Association new PALS recommendations, there's been a really strong push to limit the time attempting peripheral venous access in a critically ill child to 5 minutes and no longer. If you cannot establish access in 5 minutes, you must move to intraosseous access. Intraosseous access, if done correctly, all intravenous medications that are given into a vein can be given into the IO route. The onset of action and drug levels are comparable, and blood samples can be drawn this way, including a type-in screen. So there is absolutely no reason not to jump to this quickly if you cannot establish access into a vein. And again, this is the only way we can move on to the next box. So the next box is the fluid resuscitation box. The initial resuscitation calls for boluses of 20 cc's per kilo of saline or colloid up to and over 60 cc's per kilo until either perfusion is improved or you have signs of fluid overload. And the next part of this box is beginning antibiotics. So we'll talk a little bit now about sort of the details of fluid resuscitation and antibiotic administration. So why do we need to give fluids? Well, pediatric septic shock is associated with severe hypovolemia. Some of it is relative hypovolemia because of decreased vascular resistance, and some of it is true hypovolemia. And there's been many studies that show that aggressive fluid resuscitation early improves mortality. The most recent one is in children with dengue shock. Dengue shock, we know, is very fluid responsive, but prior to administering the routine administration of 40 to 60 cc's per kilo of fluid, the mortality was incredibly high. And this study shows almost 100% survival in Vietnam in giving just fluid boluses without any other possibilities for support beyond that. But the studies that led to these were done in the 90s, the most prominent one in 1998, showing again reduction in survival, improvement in survival by 40% in giving 60 cc's per kilo in the first hour for children with severe sepsis. There was one study done, again, after these guidelines came out. They were attempted to be implemented in a variety of different settings around the world. And in this setting, it failed. So in 2011, there was a study looking at 3,000 children in sub-Saharan Africa who presented with febrile illness and poor perfusion. And those children who were randomized to be used with the new guidelines, given 40 to 60 cc's per kilo, actually had increased mortality. And this put into question a lot of why we do this, and maybe we shouldn't. But these children were much different. Many of these children had malaria and were severely anemic, so giving fluid without the ability to give them blood made them incredibly anemic, even more anemic than they were. And this is a resource-poor country, so the children who developed severe fluid overload and needed airway support or intubation were not supplied that support. It just wasn't possible. So this is, again, kind of the need to reassess and think about, in which population you're using it. But again, it supports that in resource-rich countries, early and aggressive fluid resuscitation is, in fact, going to improve survival. So how do we give fluids? Well, you should be giving rapid boluses of 20 cc's per kilo. There have been studies looking at either IV push or pressure bag. There's absolutely no difference. You can do it either way. In the absence of signs of fluid overload, as much as 200 cc's per kilo can be administered in the first hour safely. But most commonly, we're looking again at that 40 to 60 cc's per kilo. There's no benefit to either crystalloid or at 5% albumin. These are both recommended in the guidelines. So if we move now to antimicrobial therapy, antibiotics should be initiated immediately after obtaining appropriate cultures, but should not be delayed if an LP cannot be performed safely, with again the goal being to administer in the first hour. The choice of antibiotics must take into consideration the age of the patient, the history, any comorbidities, and local resistance patterns, being sure to cover for MRSA in all children, Pseudomonas in immunosuppressed patients, Listeria and herpes for neonates, and remember too that there are some antibiotics that can be given by rapid push. These should be administered first rather than the ones who need to go in over some time, for example, vancomycin. And that way you diminish the time it takes to get all of them in. So this is a really elegant study looking at adults. This is 2,700 adults, showing on the y-axis the time from hypotension, and in the x-axis, the fraction of total patients. So in this study, you can see as time goes on, the survival decreases significantly. And in this study, it showed that each hour delay in antibiotic administration was associated with an 8% increase in risk of mortality. And you can see that by 4 to 5 hours, you're looking at 50% survival if antibiotics are delayed that long. This study was done also in children. This is a study from CHOP looking at 130 children with severe sepsis and septic shock, again, after the guidelines were published. So in this study, interestingly, as we all know, the goal is to administer within 60 hours. The median time to initial antibiotics was, in fact, 140 minutes. This is even at a place like CHOP, which we imagine everything moves so smoothly and quickly. But even there, it's hard to get them in. But at 3 hours, there's the most significant drop-off in survival. So you can see that the percent mortality in those who received antibiotics in less than 3 hours, the mortality is 6%, and more than 3 hours, it's 19%, even at CHOP. And this is the same study, again, showing the dramatic difference once you hit 3-hour delay in administering antibiotics. And again, if you remember, the time to antibiotics was 140 minutes. That's almost 3 hours. So this is so important and so crucial, and why we need to get access early and immediately give antibiotics. So now that we've fluid resuscitated our patients, they're not responding yet, and now they've moved into fluid refractory shock. The important thing about fluid refractory shock that people need to remember is that there is a wide variety of hemodynamic states that require constant vigilance and reassessment. And children do not all respond the same way once they're in this category. And this is a study, again, that I referred to before from 1998, but really shows how different children respond to sepsis. So in this study, there were 50 children with fluid-resistant septic shock. So after they're fluid resuscitated, based on the clinical assessment of the physician, placed on either vasopressors or inotropes, addressing either warm shock or cold shock. And after that, they have Swan-Ganz catheters placed. So believe it or not, 90% of patients were diagnosed incorrectly by their doctor as having either low or high SVR, and they were wrong, which is unbelievable. But when they put the swans in, they realized that 60% had a low cardiac output, high SVR state, 20% had high cardiac output, low SVR state, and 22% had a low cardiac output, low SVR state. But many of these needed reinitiation of different either vasopressors or inotropes after 24 to 48 hours. So again, this shows that we don't put swans in a lot, but you need to recognize therapeutic failure. So if you go down one path and your patient is not responding, it is vital that you reassess that patient and give them different level of support, recognizing the poor clinical assessment skills that we have sometimes. And more importantly is that the low cardiac output group has significantly higher mortality. So versus adults, where many of the initial therapies are directed at improving SVR, in children, in fact, low cardiac output needs to be addressed early and quickly because those children with low cardiac output have significantly higher mortality. And back in this 1998 study, in the group with low cardiac output, the mortality was 30% in the low cardiac output patients versus 10% in those who had, were able to maintain their cardiac output. A little brief slide about neonatal septic shock, which brings a whole different category of clinical scenarios that you must deal with. In neonatal septic shock, the hypoxia and acidosis from sepsis leads to increased pulmonary vascular resistance, maintained patency of the ductus arteriosus, and increased RV work. And this is known as PPHN, or persistent transitional circulation. So in these patients, you must reverse the RV failure and reduce pulmonary artery pressures in addition to supporting them in the same way that you would support a child. The hemodynamic response in premature, very low birth weight infants is the least understood, and unfortunately this is the group at most risk to die. And this is why, the reason is that septic shock is often assessed in the setting of RDS, or shock of other etiology, so we really don't know the contributions of septic shock versus these other shock states. The sudden change from a low resistance placental circulation to a high resistance non-placental circulation often leads to immediate decrease in cardiac output and blood pressure. And in addition, very low birth weight infants have problems with thyroid, parathyroid function, they have impaired thermogenesis, they have reduced glycogen stores, and there are also anecdotal reports of increased risk of IVH with aggressive fluid resuscitation. So unfortunately, in this very high-risk group, there's a lot to be learned, and probably they need very different management than children. I put airway and breathing last, even though we always say ABCs, because the need for intubation can happen at any time during resuscitation. But it's important to note that in children, intubation is much less commonly done for overt respiratory failure, and most of the time it's done to support the cardiovascular system. The three most common indications for intubation are the need to establish hemodynamic monitoring capabilities, the need to put in central lines, to provide mechanical support for the circulation, remembering that breathing requires up to 40% of your cardiac output, and then a variety of other things that can improve your cardiovascular function. So it is just important to remember that you should not and do not need to wait for respiratory failure to intubate, but you should also not wait for laboratory confirmation of respiratory failure to provide this for your children. So again, we go back to our ABCs, the first hour goals of resuscitation, and now we can revisit our case about Rory Staunton. So what were the missed opportunities? Well, persistent tachycardia. We mentioned again the need to reestablish normal heart rate in the first hour. This From the clinic to the ER to the discharge at ER, he remained with a heart rate of 140 in an athletic 12-year-old. This is significant tachycardia. He had a set of vitals before leaving the ER. Discharge orders were written. They checked his vitals again. At that point, he actually screened in for sepsis. He did not screen in when he first arrived because he was not tachypnic. By the time he left, he did screen in, but he was discharged anyway. Remember the CBC they sent? Well, nobody followed up on it, and it showed high white count with bands and thrombocytopenia. The parents didn't know it was drawn. None of the doctors or nurses followed it up. No one called. The parents didn't learn about it until they sued and realized the CBC had been sent. And remember the pediatrician? Well, her notes said he looked mottled. So there were early signs of poor perfusion. So interestingly enough, Rorys Regulations are now law in New York State. As of 2013, all hospitals in New York State, and that's the smallest community hospital to the largest university hospital, are required by law to adopt aggressive practices to identify and manage sepsis. And the nice part of Rorys Regulations is that there's significant parts that really address pediatric sepsis. So all hospitals are required to have early recognition and treatment protocols. They have to regularly report at least twice a year their mortality, outcomes, and what they're doing to prevent sepsis. And they have to educate everybody in their institution. And that goes to not just nurses and physicians, but respiratory therapists, pharmacists, people working in the lab, all need to be aware of what they have in their hospital for sepsis and how to recognize sepsis in their areas. There's a few other things that have been implemented in some of the hospitals who were directly involved. Some of them have countdown clocks. So when somebody screens in for sepsis, they start a clock to make sure that everyone's aware when the first hour has finished. And a discharge checklist, giving parents and patients a bill of rights, telling them what labs have been sent, what labs are still pending, what are things that they may need to be followed up with. So this is, something that's in New York, but I think has spread more widely. But New York really leads the way in making this mandatory in order to reduce sepsis. So where do we go from here? I mean, we've done a really good job in reducing mortality, but there's still a lot of children who are dying from sepsis. And I think it's interesting, I found this piece from the New England Journal from 1972, and I'll just read it to you if you don't mind. The first part of the article I didn't put in here, but he talks about how we all spend obsessive amounts of time trying to rid ourselves of germs in our environment. But what he says later is the microorganisms that seem to have it in for us in the worst way, the ones that really appear to wish us ill, turn out on close examination to be rather more like bystanders, strays, strangers in from the cold. They will invade and replicate if given the chance, and some of them will get into our deepest tissues and set forth in the blood, but it is our response to their presence that makes the disease. Our arsenals for fighting off bacteria are so powerful and involve so many different defense mechanisms that we are in more danger from them than the invaders. We live in the midst of explosive devices. We are mined. So interestingly, this was from 1972. I wasn't even alive yet. But unfortunately, in the last almost 40 years, there's been a real failure to convert this knowledge into effective strategies to prevent sepsis at the molecular level. We've done all we can at the clinical level, but we have not yet made any headway into stopping these processes at the molecular level. And this is a very much abbreviated list of what's been tried, but there have been many efforts to create an anti-endotoxin serum, so to really prevent the LPS, the lipopolysaccharide, from generated by gram-negative organisms to hit the cells. And rodents have done very well with this, but in adults and in children, because the cytokine spread is so wide, there's no way to block it. TNF antibodies. So TNF alpha is one of the strongest pro-inflammatories. Again, we've developed antibodies. Rodents are doing great. They're not getting septic, but we have not benefited from this. Nitric oxide is a very potent vasodilator and seems to affect and cause vasodilation at many different levels. There have been many different things to block nitric oxide synthase. There have been studies in people, in humans, that show better hemodynamics, but again, no mortality benefit. Activated protein C got the farthest. So this was administered to adults for a very long time who had severe sepsis, trying to stop that whole pro-anticoagulation cascade, but it's since been withdrawn from the market because it still has a lot of anticoagulant properties, and too many adults were dying from significant bleeding. And in fact, this was studied in children and never brought to market for children because of an unacceptable rate of intracerebral hemorrhage. And the complement cascade also has been studied and no clear benefit. So where do we go from here? So I just thought I'd share with you a few new things on the horizon that you may hear about. They're just kind of different approaches and different targets. One is the high mobility group box protein. This is a protein that is produced by macrophages. It has a variety of different pro-inflammatory targets. The difference of this one is that it actually comes out 24 hours after sepsis. And this has been the problem. All of these targets we've used, by the time someone comes to clinical attention, they're already 24 hours into sepsis. And so many of these cascades are already long gone. Everything's been released. Everything's in the circulation. There's no way to stop that pro or anti-inflammatory cascade anymore. This one, however, is a little bit later, and it has widespread activity. So there is potential for blocking this one and a reasonable time frame. The rodents are doing really well with this again, but I think there's human trials coming. So certainly people are hopeful that by blocking this high mobility group box 1 protein, we can stop the inflammatory cascade. What about using old targets but using them differently? So activated protein C not only has roles in the thrombotic response, but also in the inflammatory response to sepsis. So recombinant activated protein C has now been created. This has all the benefits we saw with activated protein C, but it doesn't have all the anticoagulant activities. So now you might get the benefits without the side effects of the bleeding. So this may be coming down the pike too. But I think where things are going is precision medicine. This is really focusing the management to the host response. All hosts respond differently because of their genetic factors, comorbidities, and there are 3 that have been studied quite well in children that demonstrate that if you focus on the exact human-specific host response, that we can improve outcomes from sepsis. So the first one is something called thrombocytopenia-associated multi-organ failure, or TAMOF. This is associated with a low ADAM-TS13 numbers. ADAMS13 is von Willebrand factor cleaving protease. So if you have low levels, you will develop von Willebrand factor rich microvascular thromboses. And as we talked about in the beginning, this is what leads to organ failure. So for these patients, there have been several studies showing that therapeutic plasma exchange, which both replenishes the ADAMS13 and removes these large multimers, you have a tremendous reversal in organ dysfunction and improvement in mortality. So again, if you can early diagnose these low ADAMS13 levels and recognize that children with thrombocytopenia in the setting of multi-organ failure are at risk for this, and try a completely different therapy of plasma exchange, there's a chance at improving outcomes. The next subset is the immunoparalyzed subset. So remember that there is this strong pro-inflammatory response, but in some patients it's in fact the anti-inflammatory response that's the problem. And so you are literally paralyzing the immune system. So you have severe lymphocyte dysfunction, monocyte deactivation, and altered cytokine production. The people who are at risk for this are patients who are receiving immunosuppression or who have an abnormal anti-inflammatory response to LPS or another trigger. They often make more IL-10 or less TNF-alpha. And so in these patients, you want to reduce or stop the immunosuppression if they're on it and actually give them GM-CSF. GM-CSF improves the survival, proliferation, differentiation, and bacterial killing of neutrophils and monocytes and macrophages. It promotes the migration and adhesion of neutrophils, and it may reverse long-lasting monocyte deactivation. So again, in those patients at risk for this, which can be diagnosed either by their comorbidities, the organ transplants who are on immunosuppression, or in patients who have family history, you can actually test for TNF-alpha response. So if they are, in fact, poor responders to LPS, these are the patients who would require this therapy in addition to standard resuscitation. And finally, the most complicated subgroup is the hyperferritinemic sepsis. So this has many names, which is what makes it so confusing. It's been termed macrophage activation syndrome, which is another illness completely, or secondary hemophagocytic lymphohistiocytosis syndrome. So in this model, it is believed that ferritin itself may be injurious or that hyperferritinemia may be a marker of injurious hyperinflammation. It is vital that this is differentiated from primary HLH. Primary HLH, if you remember, is a severe disease in which natural killer and cytotoxic T cells are present but have absent function. These cells have many roles, but they exocytose cytotoxic granules, they kill viruses, and they also induce programmed cell death in activated immune cells, and this limits the host immune response. Many of these children present with lymphoproliferative disease that's either B cell driven in the case of EBV or T cell driven, and these children respond to anti-inflammatory therapy to sort of stop that massive inflammation that's happening, but also lympholytics or chemotherapy that's directed at the cell that's proliferating. So it will be driven to either the T cells or the macrophages. But if you look at the hyperferritinemic sepsis subcategory, although many of them share the same diagnostic criteria, what's different is that the NK and cytotoxic T cells are low in number, but they work. And so you do need to quell that inflammatory response, but you need to protect those cells and let them recover. So if you give the chemotherapy, you have no way of those cells recovering. So in those patients, you need to not give chemotherapy. And so there's been many studies looking at children who are thought to have primary HLH, but in fact have secondary HLH, and they do terribly poorly because you would knock out the immune system that they had. And in fact, for primary HLH, the mortality is still 50% because these children eventually do die of sepsis. So it is important to recognize this sort of syndrome. The anti-inflammatory therapies that have been shown to work in hyperferritinemic sepsis are methylprednisolone, IVIG, and more recently an IL-1 receptor antagonist or anakinra. Anakinra has been shown to control this inflammation in multiple disease processes without causing significant cytopenias or risk for secondary infection. And then plasma exchange is the second sort of tier management. This reduces microvascular thromboses and stops the organ dysfunction. So confirmatory testing for primary HLH takes a really long time. So most people suggest to just look at risk factors for primary HLH. If you don't have risk factors for primary HLH, you should think that this may be secondary HLH or hyperferritinemic sepsis and think about therapy that way. So in summary, I hope that I've shown how important the first hour management is, that they're really of the utmost importance, that you must recognize therapeutic failures and readjust your therapy, and that precision medicine may be the future.